Thank you very much for the kind invitation to be here today to talk about the topic that I really like, which is management of hepatocellular carcinoma. The title of this presentation at the future is Multimodal, How to Think HCC Management Progressively. So there's a couple of disclosures, several which I think make not relevant that I'm in contact with several of them. Let's begin with what happened in 1999, last century. We had this first presentation of what is well known now as the BCLC scheme, which actually stratify patients with hepatocellular carcinoma in different stages: early stage, intermediate stage, advanced stage, and terminal stage, and linked these patients' characteristics to specific treatments: resection, transplantation, PI, radiofrequency ablation, embolization, at that time, new agents. So this way of thinking and discussing patients with hepatocellular carcinoma has been very important in the last 25 years. It really framed the discussion at tumor boards. The idea is really to cascade. You begin at the top, you have a patient with hepatocellular carcinoma, you look at different characteristics, you follow the way you want to go, and you arrive at the treatment. So you have a selection of treatment based on cascading information. This scheme has been published many times, revised, complexified, and here's one of the last scheme of this BCLC management. You see it's much more complex now. We have very early stage, intermediate, advanced, and terminal stage. You have the same kind of treatments, but you have systemic treatment here. You take into account, IFP, ALV score, Child-Pugh, the MELD, and you see that it's getting quite complicated in a way that you have Child-Pugh, but you also have preserved liver function here, which is defined differently. So I think this is a very well thought, important way to discuss hepatocellular carcinoma, but we'll see how nowadays it can be applied and what might be the limitations of the way of thinking. Let's look at this, for example. These are the trajectories of 175 patients with hepatocellular carcinoma, BCLC-A, which have been treated in burn. And in this cohort, you see that the patients had several lines of treatment. Treatment 1, treatment 2, treatment 3, treatment 4, 5, and 6. So as the patient responds or is not responding to the treatment, as the liver function is stabilized or deteriorating, you will have to change the management or discuss the patient's tumor board and select what is the best option of the patients. So this is really the key questions. Now that we have multiple possibilities to treat these patients, what is the best way to discuss this kind of treatment? So let's go through what we have actually nowadays in 2025. So for patients who need a systemic treatment, the first line is immuno-oncology. And we have three combinations here. We have Atezo-Bev, we have Durvalumab, and we have Ipi/Nivo. These are the three phase 3 studies which compare this immuno-oncology to sorafenib also for the Himalaya, and to lenvatinib and sorafenib for the checkmate. See, they are quite large studies with 500 patients, 1,668, with a follow-up of several months, up to 35 months. BCLC-B, we are addressing BCLC-C, but we still have BCLC-B patients in this population. You see 15 to 27%. different type of etiologies. Portal thrombosis, 14% in the IMBRAVE study, excluded in the others. And you see that you have clearly benefits of the immuno-oncology in comparison to TKI, tyrosine kinase inhibitors with survival and objective response rate. You see the objective response rate in the EP-NIVO is 36%. I think it's one of the highest in the field of hepatocellular carcinoma. So very clearly here, if you take the BCLC scheme, for the systemic treatment, immunotherapy, first line. It's more difficult to select the second line. We don't have really ways to do that, but the first line is very clear. We go for immunotherapy. Good. Now let's go a little bit for BCLC-B, where we go for TACE. We have some studies using transarterial chemoembolization with immuno-oncology. We have the MASLD-1 study and the LEAP-012 study. Also large studies, 616 patients, 480, follow-up of more than 2 years. BCLC-B, most of the patients, which is correct, different type of etiologies. You see the LB1, 61%, 52, 57, in the MASLD, 72, 72 in the LEAP-012, more patients with LB1, and you have the median PFS, significantly longer with the combination in both trials. You see there's 10 months of PFS with TKI, and TKI, not TKI, TACE. If you have TACE with immuno-oncology, you go to 15 months. And you also have quite a high objective response rate by mRECIST. We don't have survival data, but this hints that you may have a benefit to combine chemoembolization with immuno-oncology. Now, I asked a question to Dan Shirley about this study, why there was not an arm without TACE. At that time, when they designed the study, it was really for BCLC-B, the treatment. So yesterday, at the ESMO meeting, Peter Galley presented this study, which is an academic study in Germany, comparing patients eligible for TACE, or BCLC-B patients, for TACE or atezobev. And here, they looked at the time to failure of treatment strategy. And here they have, you see this time is much longer if you have atezobev, 15 months, quite close to the previous number, amazingly close, and TACE 9.4 months. So the study is not completed, but I mean this analysis suggests that actually in BCLC-B, immuno-oncology is also a way to go. I just put that here to remember that when you compare the two phase 3 studies with TACE immuno-oncology, you have to realize which is the design. You know, the first study, the Lencioni study, is sequential, but the other study has an interrupted design with immuno-oncology given between the session of TACE. So we can say that for intermediate stage, immunotherapy is also a good option, at least in combination with TACE, maybe even without TACE. What about transplant now? So if we go for patients who are eligible for transplantation, let's see what about immuno-oncology and immuno-oncology in these patients. So there is a review of 91 cases of patients. This is a systemic review and individual patients' data. This study focuses on patients with hepatocellular carcinoma who have been treated with immuno-oncology prior to liver transplantation. So we had such a patient, we downstage with immuno-oncology, listed it transplanted. So they looked at the outcome, and they found actually that most of these patients are doing well. They had few HCC recurrence, 9%. They had some allograft regimens, and here the time between the last immunotherapy treatment and the transplantation is very important. It seems to be at least 3 months if you want to reduce this possibility to have a rejection. So what about transplantation? So this is a very difficult questions. Can you even think to use immuno-oncology in patients with recurrence of hepatocellular carcinoma after transplantation? So not a surprise that there are very few data in the literature. But what we can say is that immuno-oncology in this setting is not very efficacious because only 25% of the patients show a positive response. But it is quite risky, which is not surprising. 20% of the patients had a rejection, and of these 20%, half of them died. So it's certainly not something which is recommended to do after transplantation. We need to have more data, that we know more about the type of immunosuppression that we can give, because it looks like there was less rejection on CNIs, calcineurin inhibitors, in comparison to mTOR inhibitors. But we need more data here. But nevertheless, before transplantation, I think we have enough data to consider it. So immunotherapy now is also moving on the transplant. So let's go now a little bit on early stage, a very early stage. What do we have? We know that after resection, there is a high rate of recurrence. It's about 50 to 60%, and this may happen before 2 years or a little bit after 2 years. So this kind of recurrence rate is quite high. We know that so far we distinguish two types of recurrence. There's a recurrence early on, which is probably really a recurrence of the same tumor. The risk is based on tumor size, tumor number, microvascular invasion, AFP. And you have a recurrence occurring years later, which is probably a new HCC, depending on the HCC etiology and the cirrhosis. And they don't have the same prognosis. If you look at the cumulative patient overall survival, you saw in blue here that the early recurrence group has a lower overall survival. So what can we do here? Can we use adjuvant therapy? Adjuvant therapy was used with sorafenib. It's a STORM trial, completely negative. Now what about adjuvant immunotherapy? So you remove the tumor, or you embolize, or you ablate the tumor, and then you use immunotherapy. So this has been tested in the IMbrave 050 study with atezobev. And this study, at the first interim analysis, which was positive, but then it turned out that there is no difference. It seems to delay the recurrence, but you don't have really an effect long-term on the recurrence of hepatocellular carcinoma. Other studies are ongoing, 3, Checkmate 9, Keynote 937, and HAL2 with different immuno-oncology. It will be very interesting to see what these other trials will show. But if adjuvant is not working, what about neoadjuvant immunotherapy? You give the immunotherapy, patients had a tumor, then you remove the tumor, ablate the tumor, and see what happens. So there's extremely few data on the neoadjuvant therapy in hepatocellular carcinoma. These are with the cabozantinib, nivolumab, cemiplimab, nivolumab, ipi-nivo. You see small numbers, endpoint safety, some durations of treatment, and the results most of the patients were resected and show a major pathological response. But I mean, this is extremely limited. This is not immuno-oncology. And so it's something that needs to be considered, that needs to be discussed, and eventually we need certainly more data. When we can say adjuvant therapy following hepatocellular carcinoma resection ablation is not currently recommended, the BRAVE study was negative, we are waiting for the others. Neoadjuvant therapy, I think deserve to be tested, but then there are really big questions. What means resectable? It's not the same definitions around the world. How many cycles of immuno-oncology? Because you delay the surgery, and so how long can you delay it? What will be the endpoints, recurrence-free survival? Many open questions which still need to be discussed, but this is certainly an area where we will see in the next years more data. So it looks like we have immunotherapy across the board. You may discuss immunotherapy for very early stage, intermediate stage, and advanced stage. So that's a little bit, I have to say, kills the purpose of the BCLC scheme. And then we have this nice commentary by David Pinato, immunotherapy at all stages for hepatocellular carcinoma. So if we cascade patients' characteristics to find a treatment, and we end up all the time with immunotherapy, this is not really the way to discuss these patients. So we have to think differently, I think. And so let's rotate 90 degrees this scheme. Now you will have different characteristics at the top, and then you will have different treatments that you can address, but you will do that differently. And this is what has been proposed by a group of Italians. This is a paper published in GHAP in 2024, Trevisani as the first author, where they speak about therapeutic hierarchy. The idea here is to always begin with the treatment we could have the most benefit for the treatment, for the patients, like, liver transplant. So you begin the discussion now by the treatment. So you will use the same arguments, or you will use the same characteristic, but the perspective is fundamentally different. You begin with the discussion to say, does these patients can have a liver transplant? And so you look at some characteristics. Is the patient fit enough? What about the tumor feature? What about the liver function, liver dysfunction? It is something we can do, we can't do at our center. And so then if liver transplant is not possible, to go to the next one, which is the most beneficial for the patients, mini-invasive liver resection. Then liver resection. Then you go down, percutaneous ablation, video laparoscopic ablation, intraarterial therapies, then systemic treatment, of course, and then best supportive care. Okay, this is a very interesting way to discuss, but the beauty of this scheme is that you can repeat this discussion. So you are not cascading, but you are doing like a watermill, We have seen that the patients now have several treatments. We have seen that in Bern up to 7 for BCLCA patients. So if you go back to the tumor board, you will begin the discussion at the top. And this is really where I see a benefit for the patients. You treat the patients with one of these treatments. Then you have to discuss what will be the next treatment. Or you begin by the top and you go down. So each time you discuss treatment in patients with hepatocellular, you always begin by the one which has the most benefit. I think this is really change in the perspective to the benefits of our patients. So this is a small interview that I conducted with Professor Vitali about that. You can go on the site and listen to it. But that's what I wanted to share with you today. and how we have to think and rethink now in the management of patients with hepatocellular carcinoma. Thank you very much for your attention. I'm happy to take questions if there are.